Okay, Ashish
Yeah, thanks.
KC, welcome. So, Ashish, you are a senior lecturer at the Gothenburg University and will speak about your favorite subject, neonatal resuscitation. Welcome.
Yes, thank you. So I don't need to preach the converts on newborn resuscitation, but in the next 10 minutes, I'll just try to frame this workshop in terms of newborn resuscitation, and it's also the esteemed audience on how can we contribute as a Swedish researcher to global health. So I'm just trying to frame this in terms of the uh, political priority. So how can newborn health and newborn resuscitation being a political priority in the global agenda, and how can we contribute to this process? So back in 2007, Jeremy Schiffman and Stephanie Smith had developed this framework on these issues, ideas, actors, and political context. So anything that you come in context is always based on issue. So if you see HIV came as an issue not because of a disease, but as a civil rights movement in US. So back in 1950s, when the civil rights movement started, it marred with the HIV disease that came in 1980s and then became a big issue. So by 2000, it became a big global financing hub for any disease to be prevented. So no any disease then had been given global priority. So I'll just frame this out in that context on how can newborn resuscitation, newborn health be framed as an issue, idea, actor, being an actor, and then into political context. So as an issue in context, as Professor Joy mentioned, almost 6 to 14 million babies do not breathe at birth and require resuscitation. Of those who are breathing, or who are not crying, among them almost 11% of them are not crying, and among those who are not crying, half of them are not crying but breathing, half of them are not crying but not and also not breathing. So if you need to understand this between these two figures of not crying but breathing, and even those who are not crying but breathing require some kind of resuscitation and effort, and these are at high risk of having transient bradycardia and transient tachycardia. One of my colleague and PhD student Auntie had done this study on this tachycardia and bradycardia between those babies who are not crying but breathing, and they are both at the risk of mortality. So this is an issue in place. Now, in terms of the credibility of the indicators, so under the leadership of Joy as an EN but studied done in 3 countries, in Bangladesh, Nepal, and Tanzania, what we found was that of these babies who were born in these hospitals in low and middle income settings, most of them are not ventilated timely. The median time to ventilation, if you see from this graph, is almost 3 minutes. So a first of a baby who is not breathing is getting ventilation at around 3 minutes. And if you see the heat map, you see that most of the babies are getting resuscitation only almost after 3 minutes or almost at 9 minutes. So the latest is at 9 minutes. So the first time for babies who are not ventilated is almost 9 minutes. We have evidence that for these babies who are requiring ventilation, observation is the best method for measuring them. So if you have an observer at place in a resuscitation corner, they are the ones who can accurately measure the babies requiring resuscitation. But the standard procedure for measurement in most of the settings, including ours, in Swedish setting is basically the reporting being done in the registers. And WHO has recommended for routine measurement to use babies who require ventilation using any device with denominator as number of live born and stillbirth, and using in the routine registers. So this is an issue in place. So there is a lack of timely ventilation in place. There is a measurement that's credible enough to be measured over the period of time. Now, in terms of the ideas in the internal frame that exist for newborn resuscitation, we know that there have been a lot of work going for low and middle income settings using the Helping Babies Breathe, where it can reduce mortality, but only training doesn't help. So what we have learned over the period of time is that if we train a health worker for once, he or she can improve the skill and knowledge just after training, but have a skill decay over the months and period of years. So what is required? There is a requirement of a continuous process of a PDSA process of weekly meetings. There's a requirement to have progress report, progress monitors, and this can reduce mortality as well as improve performance. But what we have seen is that these are not sustainable over a period of time. So how can we sustain this performance, even if there is a reduction in mortality after trial? So what we have seen is that a low dose, high frequency training with the simulated in the settings has and maintain the skills over time, but has a low application in clinical cases. So studies done in Tanzania as well as in DRC Congo has shown that if we train the health workers and do a retraining every time, there is a skill retention in place, but doesn't translate into clinical setting. So right now there's a work being done in terms of providing real-time guidance on resuscitation. And this guidance of resuscitation is not by human, but through a machine learning process. And this work that's been currently being carried out has a whole package of LiPON system, where there is an tablet which monitors the baby's movement, sound through audio recording and video recording, and provides a light feedback on what needs to be done. This is not only providing observers or clinicians in terms of what needs to be done next, but also providing measurement in an accurate basis. So as we said, there's an issue with measurement for newborn resuscitation, but at the same time, there's also an issue on providing guidance to the health worker, especially in settings where there are almost 8 deliveries taking place parallelly in a single delivery room, and there is only one health worker. So if you see a setting where there is one health worker providing care for all the mothers at the same time, also setting one newborn, then he or she really requires guidance on what to be done next. Besides, this system is now generating data on heart rate, also data on epiglottic closures, basically on how is the ventilation being done, and also in terms of the effect of ventilation in terms of the performance of health workers. So these are in place. Hopefully by 2027, we will have a new AI system to provide guidance to them, and hopefully also testing these systems in terms of their acceptability as well as the fidelity in low-income setting. And this we are right now doing in Nepal, Tanzania, and DRC Congo. So in terms of the Swedish actor, so as Joy mentioned, for the Every Newborn Action Plan, there was a big push and rally from different actors, from UN agencies, NGOs, as well as from funders to basically have every newborn action plan laid out and been endorsed by in the World Health Assembly. This has been a major landmark been done for almost 14 years of work that Joy and team had led. But in terms of Sweden, and I'm just putting it into the context of the Swedish actors, we have academic institutions. We have Karolinska Institute, we have Lund University, we have Uppsala University, we have Gothenburg, Umeå coming together as academic institution. And we have only few associations basically making this noise that we need to act for global newborn health. But we have very less media. So if you see the color marking, so a strong color marking is the green one is academic institution, association, lightly green. The media, there is no media presence. And civil society, do we have civil society movements? What we are talking right now is for health and right for children. Is there a civil society movement for that one? Who is going to lead this process? And then pressure groups. As I said, HIV couldn't have been a global health disease without being marred with the civil rights movement. And this is, I think, what we need to think of. And as I said, can we make this as a political economy of about sick and small newborns in Sweden? Can Swedish politicians take this as an agenda for their next voting rights, that we need to save all newborns who require resuscitation, as 2 of 3 of newborns do not receive timely and effective ventilation? We need to save them because these are the children who are going back to the society being poorly developed, disabled, and also will come back not only to the low-income country, but also to our settings, in high-income settings, as a part of migration. How are you going to deal them? And finally, how are you going to address the agenda of 2030 that we have, what the government have committed to? So in finally, the issue is too much, we all know, as Joy mentioned. The idea is in abundance, we all know that. We are actors in place, we are relevant, but we are really engaging at a political level, at a policy level, to basically have them engage, that account them as both in terms of funding, but also making that we are at the high income settings, contributing to the global south, global health for newborn resuscitation. Thank you very much.
Thank you so much, Ashish. And I think now it is time for that Swedish fika.